Hello, everyone. So glad to see you all here and many familiar faces here in the attendees. This is part of our 2022 Research for the Public Good Conference at APUS. This is our internal research conference to highlight faculty research and support research in general at the university. If you look at the event site that Kelsey dropped in the chat, we also have some pre-recorded on-demand presentations from some of our faculty researchers, as well as student lightning talks, which are 3-minute presentations that you can vote on right now. We do have a public voting period and award some prizes there. So take a look at that event site, and also please join us throughout the rest of the week as we have live presentations throughout the week. So I'm very happy to introduce Dr. Vicki Graham, who will be presenting on research from her faculty research grant here at APUS. And I will turn the floor over to Dr. Graham.
Thank you, Dr. Douglas. Thanks to all of you for being here today. I'm happy to be here. I'm going to talk about the project that I collaborated on with a research team that I work with at Cincinnati Children's Hospital. We studied emergency department use by athletes in an urban setting. Just some disclosures. This was funded by a 2021 APUS Faculty Research Grant, and we're greatly appreciative of the support we've received from APUS for this research. The project was approved by the IRBs at both institutions, and none of us have any. I'm the only one presenting, but none of us has anything to disclose. So just a little bit of background. We understand that millions of kids participate in sports, school sponsored sports across the United States. And when we're physically active, which is a good thing, there's also a tendency for people to become injured. And there are a tremendous amount of injuries that occur each year as well. And unfortunately, only about 37% of the secondary schools in the United States have a full-time athletic trainer on site at the school to manage these types of injuries, some of which could be life-threatening, and they occur primarily after school and after school hours, and sometimes on the weekends and in the evening. And many institutions, many schools don't have anyone there to provide care. Some of the effects, for those of you that aren't familiar with athletic trainers and what they do, athletic trainers are healthcare providers, and they're trained specifically in managing emergent conditions, medical conditions that are emergent, acute, and chronic. They're on site in the traditional setting. In a sports setting, they're on site for practices and events. They help manage injuries when they occur, after they occur. They provide rehabilitation services for those injuries. And they're also very important in emergency preparation to manage events when they do occur. We know from the literature that schools with athletic trainers have improved recognition and management of concussions. They have lower rates of recurrent injuries, so re-injuries, and they have lower rates of musculoskeletal injuries overall. Some other important things to understand about athletic trainers are that ATs implement procedures that help manage high-risk medical situations. So things like exertional heat stroke, exertional sickling, cervical spine injuries, sudden cardiac arrest, all those types of things can be life-threatening if they're not managed properly. So athletic trainers implement procedures to manage those and to prevent them. Schools with athletic trainers are much more likely to have an emergency action plan in place. And typically, athletic trainers reduce visits to the emergency department by managing injuries at the school and triaging them to the appropriate outpatient providers. Now, lots of people will say, well, we have sports and it seems like we should have someone there to help take care of them. And one of the biggest perceived barrier anyway by athletic administrators and school administrators is that the common common tale is that we can't afford an athletic trainer. And you can see in one study, the budgetary constraints were cited by 76% of athletic administrators. Other things that are cited as perceived barriers are that the school is so small, so we really don't need one. We don't have that many sports. We don't have football. We're in a really remote location, so it's difficult for us to find someone. There are a number of barriers that are out there. Some of the interventions suggested are seeking services for a school to seek services by contracting with hospitals, physician practices, or PT clinics. And this is done and been done for many, many years. But the bottom line for any entity that provides contracted services is that they want to see a return on their investment. So if they're gonna pay an athletic trainer to be on site at the school, the bottom line is what are we going to see back in the form of, are we going to see patients when they're injured? Are we going to see surgeries? Are we going to see people coming into our PT practice with injuries that can't be managed at school? So those are some of the barriers to hiring ATs. And this is exacerbated a little bit in urban areas. We know that there are already healthcare disparities in urban areas that are typically low socioeconomic status, SES areas. We know that school systems in those areas typically have less access to athletic trainers. And we know that families typically use ED services more than families in higher SES backgrounds. Many families in these areas that the low SES areas, traditionally that's where their family goes for care, is to the emergency department. And they don't have primary care physicians, so the ED is basically seen as their point of access into the healthcare system. That is their primary care. And we know that ED services in general have much higher costs relative to any services that are provided in a school-based health plan or a clinic-based service, outpatient service, both for the health system and for the patient's families. So we have a lot of challenges in urban areas that already exist that we also have to kind of consider. So taking that all into account, in this particular situation, the hospital sports medicine service already provides athletic trainers for the local public school system. And that particular area is primarily low SES. For our purposes, we considered that low if it was greater than 66.6% of students qualifying for free or reduced lunch or meals. So that's how, for our study, we categorize low SES. Almost all the student athletes have government funded insurance, so they're on Medicaid, but in this case, the hospital actually administers that insurance plan, administers Medicaid for them. It's not called Medicaid, it's called something else, but the hospital is administering the insurance plan, so it's in the hospital's interest to find ways to save costs. Sorry about that. So we thought about how can we demonstrate the value of the athletic trainers to the hospital. The hospital obviously wants to try to save costs. Can we demonstrate that we're reducing the burden on the emergency department and the clinical staff in the emergency department? Clearly, we can demonstrate that there's a positive effect on the community. So we were looking for ways to do this and to explore these kinds of questions. So our primary aim was really just to describe what was happening, who's going to the emergency department, and what are they going for? It's the bottom line. It was very, very simple. So we're describing use. We do have some schools where the athletic trainer does see the middle school or junior high school student athletes, so they were included in the data set, but we just looked at the ED visits by creating a database. We had a de-identified data set, so we didn't know who any of the patients were. We were able to track them by their medical record number. Anyone who was on a roster was a rostered student athlete in one of the schools that the ATs at the hospital were providing care for was included in that data set. And we matched them, the MRN, the medical record number, with emergency department visits 3-year period. And you can see the time frame. It was over academic years. It was fiscal years for the hospital, which coincide basically with academic years. So 2019 was actually July 1 of 2018 through June 30th of 2019. So the total time frame for the study ran from July 1 of 2018 to June 30 of 2021. So we have 3 years of data. Our statistician cleaned it, removed duplicates, records with missing data, etc., and we created this database. So, what we have is we have 3 years of data. We had a total number of 6,468 student athletes. We had 14 schools the first 2 years and 11 schools in the data set the last year. And then you can see our number of ED visits, total 2069 over the 3 years. A couple of things that you'll notice is that in 2020, we dropped quite a bit. And then in 2021, which remember is June 30th of 2020 through July 1st of 2020 through June 30th of 2021, that academic year, we had really about half of the visits we had in 2019. Excuse me. And we really attribute the drop in these numbers to COVID. Excuse me. To COVID, basically because midway through 2020 or in March of 2020, most things shut down because of the pandemic, and hospitals other than people who were sick with COVID, no one was going to the hospital. ED usage dropped off significantly. It's barely, it's just coming back to pre-pandemic figures for usage of the ED right about now. So we think that this drop was really related more to COVID than to anything that was happening at school. We weren't in school a lot of parts of the time, and athletics was affected because of cancellations or because of seasons being lost, things like that. So that was kind of a confounder for us in looking at the data. We went through all the diagnoses, we coded them. Our 2 physicians that are part of the research team coded them as being either sports related, and that would mean they were some type of musculoskeletal injury or a concussion, mental health related, which I'll talk more about a little bit later, but depression, anxiety, etc. And then other, which we categorize as not being related to sports or mental health. And that would be things like people in for COVID or other viral illnesses, or people in for some type of an injury that clearly wasn't sports related, motor vehicle accident or something like that. And then general medicine that wasn't that were known not to be related to sport. We also had one of our research team members meet with each athletic trainer from the schools to determine whether they were aware of those emergency department visits by their student athletes. And I'll talk a little bit more about that as well. So our key findings, we had a lot of people visit the emergency department. We were somewhat surprised by the number of people that went to the emergency department. You can see the data here over the 3 years. Total emergency department, the injuries that we categorize as being sports related, mental health related, and the other. And again, we were really, we feel like we can't do much about the other category, but we were surprised at the number of people that we saw that went with something that was musculoskeletal. And we don't know for a lot of those whether or not they could have been managed outside of the emergency department. Now, we looked at the top diagnoses just by category. So the way these are coded in the emergency department, the physician or the provider will code several different things for an injury, and we took the top code, the first code that they entered. So some of them will say injury of knee, injury of ankle, so that's clearly musculoskeletal. So injury of was the highest diagnosis in that category. Here you see mental health. I have a red star there because that's not musculoskeletal, it's mental health. Fractures musculoskeletal, so there's no star by anything that's musculoskeletal. Pain of ankle, knee, elbow, sprain of, sprain of a joint, contusions and concussions. So we had mental health in its own category, and then these 3 yellow stars are all things that were things like viral illnesses, sexually transmitted infections, and other things like abdominal pain that were not sport related. So these are our top diagnoses in the various categories when we broke them down that way. We asked the ATs, I mentioned that we did chart reviews. We asked the ATs if they were aware. We went through one by one on every one of these encounters and to determine, number one, if the AT had referred the person, the student athlete. And you can see that a handful of these visits were referred by the athletic trainer. So someone's seen at school, it's after hours, there's concern that there may be a fracture, and they're sent to the emergency room. Something like that. Then we want to know if the AT was aware of the visit, even though they didn't refer them. If the athlete came in the next day and said, yeah, I went to the ED last night because my knee was really hurting me, or I was throwing up and didn't stop throwing up, and my mom took me to the emergency room. So we found out that that wasn't really happening. Very few of these visits were being reported to the athletic trainer, which is a significant issue. So you can see of a total of over 2,000 visits, there were only about 347 that the athletic trainer was aware of, either because they referred the athletic trainer themselves or because the AT or the student athlete came in after the fact and reported that they had been gone to the ED. So this is kind of a big issue, the awareness issue. When we crunched the numbers, the athletic trainers were only aware of about 14% of those ED visits, and that results in a huge problem with continuity of care. It's difficult to take care of somebody if you don't know that they're having a problem, and even if it's not sport related or it's something that doesn't necessarily affect them in sports, going to the emergency department or to any doctor and being put on medication for something and then not reporting that can cause an increased risk. I mean, there are medications that make you more prone to exertional heat illness, for example. Excuse me. So, if someone's gone into the emergency department because they've been vomiting all night, and maybe they got some fluids while they were in there, but they don't report that to the athletic trainer, and then they come in and they go to football practice today in August when it's 90 degrees out and 80% humidity. There is tremendous risk of much worse outcomes. So that's a person that's going to drop during practice with exertional heat stroke. So that's just one reason that there has to be better continuity of care, and an example of why the student athletes really need to report this and communicate their medical conditions to the athletic trainers. Another thing that we found in this were that we had 11 emergency department visits by student athletes who'd been referred by the athletic trainer directly to sports medicine clinic at the hospital, and not only had they been referred, they actually had the appointments. And despite that, the parent or family member decided that they needed to take the student athlete to the ED that evening. We're unsure of for what reasons, but I think that just points out another challenge in this population in the healthcare system meeting the needs of the people that need to access it. When we looked at the mental health related issues, you can see here in this image, 8.1% of all our emergency department visits were for mental health issues. We actually had the same number of student athletes seek care for mental health related issues as we did for fractures, which we found to be pretty interesting and pretty alarming. You can see that there's a wide range of different types of diagnoses here. Depression is certainly one of the higher ones. Anxiety is another high one. These are certainly common in the population that we're studying, but the fact that they, did end up in the emergency department is a little bit concerning. And I think that points again to some issues with the inability to access mental health services outside of the emergency department in this particular population. So in it kind of to tie that up from a mental health standpoint and a socioeconomic status standpoint, and then tying in COVID to all that, we know that people in low SES areas have poor access to care. We also know they have increased mental health issues in general. We think that our data probably underestimates the extent of the needs of that population in the last 2 years of our study, just because of no one was going to the emergency department. We think people that went during those last 2 years were probably in more of a crisis than they would have been in another year from a mental health standpoint, because we know that overall emergency department use was just down significantly in those last 2 years. We are aware of a couple of other studies that have cited that there was an increase in anxiety and depression in teens during the lockdown periods of COVID and during times where school was remote. So, we think that probably the mental health issues in this particular community are probably a little worse over the last 2 years than the data shows. So some other key points about our mental health findings. I think it just highlights the prevalence of these issues in adolescent student athletes, which is our population. It reinforces the need for our athletic trainers to be aware of this and to kind of put it on the radar, for the ATs to put it on the radar with coaches and athletic administrators at the school. It supports the need to educate the student athletes that the AT is a good resource for their mental health issues, and that they can be a resource to get students help when they need it. It also emphasizes the need to have a mental health referral plan in place at the school for student athletes. And this is part of, best practices. It's been recommended by national organizations, medical organizations, the American Medical Society for Sports Medicine, and the National Athletic Trainers Association. Both have position papers on having a mental health referral plan in place. So this again emphasizes the need for that. And it also identifies a gap in continuity of care for those issues. It's kind of clear that within that population in that community, there isn't anywhere else for them to go but the emergency department. And when they leave the emergency department, where do they go from there? And what support is there for them? And if that information isn't coming back to the school, if it's an athlete, back to the athletic trainer, back to the school nurse during the day, there's a big gap. So we have some opportunities for quality improvement here. We understand that there are some issues with continuity of care within the hospital services. We've had student athletes go to the emergency department, and athletic trainers that are employed by the same hospital and team physicians employed by the same hospital don't know that those athletes have gone, and that's been addressed already. We also know that there's an opportunity for quality improvement in regard to educating the student athletes about communicating their medical information back to the athletic trainer. If they do see another physician, do see another healthcare provider, or see someone in the emergency department that needs to come back to the AT, we need to know about medications. And then we also, clearly can do some things we've talked about in raising attention and addressing some mental health issues for this population. So next steps, we have based on what we learned in this study, we've got a current study that's ongoing about outcomes of knee and ankle injury care that the athletic trainers are providing on site at the school. And then we're also looking to, with the goal of reducing emergency department usage for ankle injuries, because that's one of the knee and ankle injuries were really the two most prevalent musculoskeletal injuries seen in the emergency department. And they're also some of the most common athletic injuries. We're going to look to, with the goal of reducing use of the emergency department for ankle injuries, have a targeted intervention for ankle injury care and management. There will be an education component, some care components, involved in that, and we're in the process of developing that proposal. So that's kind of the next steps for us. This is our research team, and I'm happy to answer any questions in the time that we have left.
I have a question from Donna Ross about concussions, and she asks, are concussions on the rise, or are diagnoses increased due to stricter policies?
I would say that I don't think there's more concussions. I think that there's more awareness. I don't think it's stricter policies even. I think it's more awareness in general about the injury. We know more about it than we did 15 years ago. I think there's a tremendous public awareness about it. Certainly the policies, the state laws have helped at the high school level. But I think it's really recognizing it, taking them seriously, where, you know, in the past, people sort of kind of blew them off and poo-pooed them and talked about people getting their bell rung and things like that. And I think we have a much better understanding of how to recognize them, and of the fact that there are some long-term consequences that are not desirable for anybody.
I had a question, Vicki, about with COVID happening and a lot of students being out of school and probably out of sports for a period of time during COVID. Are you seeing, or would you anticipate more sports related injuries as some of those sports really come back to their full kind of implementation, and students coming back into it after maybe being off for some period of time?
Yeah, that's I think we would anticipate that, and I think I'm sure there will be some studies that come out in the next couple of years that answer those questions, Jenny, because they came back, they're back, they've been back. But I think the biggest time was coming back in the fall of 2020 or the winter of 2020, depending on the sports season for a lot of those athletes. And I think I know just anecdotally from talking to people, some of my colleagues, that they certainly saw increases for some of their, especially in the high school setting, a little less so in the college setting, but certainly there's, depending on the sport and the ability of people to get in and do the kinds of workouts that they're accustomed to. It was certainly a concern, and something that likely happened, that there was an increase.
I'll ask one more thing, and that's more about the parents' role. Because you're talking about, student athlete maybe gets injured, they might have been seen by a trainer at the time, and then parent decides they have to go to the emergency department. What do you see as the parents' role? And I don't know if there's a general protocol, because it's not my realm, but the parents' role in communicating back and forth between the athletic trainer and the student athlete in terms of what happened and that visit and their follow-up.
Yeah, I think that is I think that's part of the challenge too. I think the students need to be educated, and the parents do as well. And I think we recognize that there are challenges with I think there are challenges. Different schools have different challenges. Some of the schools, the athletic trainer has been there several years, so the parents know this person and know who they are, and communication is better. I think there's also a perception that if it's not, if I didn't do this at sports, or they didn't tell me I couldn't play, then I don't need to tell them. We also don't know how many people, how many kids are, told by their parents to, hey, make sure that you tell the AT this, that we went to the ED last night because your ankle was really hurting you, and the athlete just comes in and they had an x-ray last night, it was normal, so now they feel better about it. Yeah, their ankle still hurts, but I'm going to let the AT take care of me now, and never mentioned that I got seen. So we don't have an idea of some of that. So there are certainly challenges. The parents do play a role. And that is that's part of what we're looking at as far as trying to, determine the best way to communicate this information and get action back on it as well.
Thank you. I know we're up against time. Does anybody have one more question they want to ask? Seems like everybody's set. I want to thank you all so much for being here, and thank you so much, Dr. Graham. This was really excellent. I know it was a lot of hard work at the beginning, and it's really great to see the outcomes of the study so far. I'm really looking forward to seeing the next phase of everything.
Thank you everyone for coming.
Thank you so much, everyone. Hope to see you later on.